For this next session, Infections in Diabetes, I would like to invite Dr. Chandni R. She is she's MD, PhD, PG, DML, FIC, FRCP, Edinburgh, Professor of Medicine, HOD, Department of Emergency Medicine, Medical College, Calicut. More than 40 publications in various national and international journals. She's invited faculty at various national and international conferences, worked as a principal investigator and sub-investigator in various clinical trials. She has published a book, Practical Guide on Insulin Therapy for Beginners in 2018, authored chapters in various textbooks, and also active member of various communities. And I welcome you, ma'am, to the program.
Thank you, Dr. Yasin, for the kind words of introduction. I am very thankful to Dr. Jyoti and the entire team behind this JPEF 2024, and I congratulate for organizing such a nice scientific program on diabetes every year with the same content and success. I will be discussing on infections in diabetes. We have just listened to on preventive cardiology, and most of the things and slides I will be presenting are from our own patients, and because these are the ones we are going to see in our day-to-day practice. To beat diabetes, that it's a global emergency, and we are seeing that our population will be continue to do the same for the many years to come. So we'll be having more number of diabetic patients. We are having the largest prevalence of diabetes in the world. And we know that there are recognized complications of diabetes which are daily, actually we are screening in our clinical practice. Diabetes and infection, it's a close association, and it is also important that there are unusual infections, and we should know how to prevent this and what are the advices we are supposed to give to our own patients when we manage or how to prevent these things in diabetes care. So this is what I have already emphasized, and the number is so huge that every time when the atlas comes, we get really frightened what is going to be. So it's an 84% increase, that is of South Asia. So that is why, and this is actually taken from the idea of atlas of 2017. It has very clearly represented the complications, the 10th atlas that we are seeing now, but it's from the 8th, and it has emphasized the important complications of periodontitis, JDM, diabetic foot, ESRD, CVD, as well as retinopathy. So what I am going to discuss is what are the complications related to infections that we are going to see in our patients. Patients living with diabetes and infections is important because they are more susceptible to all the infections that we see. Patients having high blood glucose or higher HbA1c are actually more susceptible to infections, and certain infections are more prevalent. Diabetes associated infections, as we say, and more than that, they have unique features when they occur in diabetes. So if we are really not tuned to it, we may miss the infection, and patient may land up in sepsis and other complications. So what are the common infections that we see? Obviously, diabetic foot infections, urinary tract infections, superficial fungal infections, mucor, malignant external otitis, emphysematous cholecystitis, pyomyositis, and necrotizing fasciitis. So why there is unusual infections in diabetes? We'll just see what are the causes for this predilection. But we have infections that are commonly associated but non-life-threatening, that every day when a patient comes to us, they will have something to show, a paronychia or some other flurangle or all those things they will be asking, and will be prescribing antibiotic or prospective treatment. And there are infections that are commonly associated and can be life-threatening and virtually unique. So commonly associated usual infections are actually the fungal infections, oral candidiasis and the sort, as well as the periodontitis. Periodontitis is not very life-threatening, but actually it's very much associated with the progression of diabetes and diabetic cardiovascular disease. These are the unusual infections which I have already listed, and among them I will be showing cases or some of the practical experiences that we have in this patient management. Why there is higher predilection for infection in diabetic patients? There are host-specific factors and hyperglycemia-related impairment of the immune response. What are the factors responsible? That is hyperglycemia-related impairment of immune response, defects in leukocyte function, angiopathy, neuropathy, dysmotility syndromes, all predisposed to infection. And more than that, there is increased asymptomatic skin and mucosal colonization with Staph aureus and Candida albicans. So skin is the most protective organ, and if there is any breach in the skin, the patients are more predisposed to development of infections. And the organism-specific factors are Candida albicans, there is glucose-inducible proteins which promote adhesion to buccal and vaginal epithelium. Rhizopus species, they thrive in high glucose in an acidotic environment, so there is a higher risk in diabetic ketoacidosis. Mucor, as well as the deferoxamine therapy and iron overload, all are predisposing factors, and they also thrive in acidic medium. Burglarria pseudomole, the macrophages killing is impaired in diabetic patients. And this is another interesting observation, deferoxamine therapy and iron overload. This deferoxamine is actually binding to the iron and iron chelate, and it's forming as a siderophore, and it enhances the entry of the mucor into the host. So that is why this is a high risk in patients who receive these drugs for iron overdose. So there are many challenges with necrotizing soft tissue infections in diabetes, and the most important thing is fever is often absent, and the signs and symptoms may be subtle, but there is excruciating pain out of proportion to the suspected cause is an important clue, and it could be absent in patients with neuropathy or patients already has received treatment with NSAIDs. Acute hand infection, we have to have a history, focused examination, investigations, and early intervention antibiotic. There will be a lot of differential diagnosis, and diagnosis is always challenging. This is an emergency, potentially life-threatening, deep neck space infection. Usually positive organisms are mixed aerobic and anaerobic infections. Immediate surgical intervention and debridement with broad-spectrum antibiotic, and we have to modify the antibiotic treatment after sensitivity test. So this is a review article that we have come up with medicine-resistant Staph aureus in diabetic foot infection in India, and I'm so glad that I was a co-author with Vijay Vishwanathan, and Dr. Sharad Pensesa sir is not with us, but I'm just remembering him because of his contribution to diabetic foot education and management. Ponius megacarine is not so uncommon, but it is very life-threatening. It's a fulminant form of infective necrotizing fasciitis of the perineal, genital or perianal regions, and the management include early surgical debridement, broad-spectrum antibiotic therapy, but the mortality is as high as 40 to 80%. One thing we should always remember in patient coming with uncontrolled blood glucose, fluctuating blood glucose or worsening of sensorium or DKA, we fail to examine two areas. One is feet and second is external genitalia, and we are, as well as there could be perianal abscess and infections. So we have to have a look on these areas, otherwise we may be missing life-threatening infections in these patients. So this is a case that has presented, and it has actually managed by our surgery department, and when I discuss with them, it is not so uncommon. We may not be seeing, because these cases all go to surgical department, around 15 to 18 cases per month in Calicut Medical College, and it's very, very distressing and demoralizing for the patient. And we have to have very considerate and supportive care, including the management of diabetes, debridement, dressings, and continuous care of this patient till the patient recovers. Emphysematous pyelonephritis, most of the time we have discussed in many occasions, and patient comes with hematuria, pneumaturia, severe sepsis, frank pain, and these cases may be diagnosed with a chest X-ray, CT, abdominal X-ray or CT for diagnosis, and extent of infection will help in deciding the management. Emphysematous cholecystitis is a surgical emergency, acute infection of the gallbladder. Common organisms are Clostridium, Escherichia coli, Klebsiella pneumonia, mortality is very high. Gangrene and perforation of the gallbladder increases the mortality. So this is also we see, this is malignant external otitis. Patient comes with severe otalgia and otorrhea, and anti-pseudomonal antimicrobials to be started, and the patient may have complications like skull-base osteomyelitis if not recognized and managed correctly. Mucormycosis has been a problem, and it has been a very big problem during COVID-19 infection because it's an opportunistic fungal infection, rapid progression with vascular invasion, thrombosis, necrosis, rhinoorbital cerebral pulmonary and cutaneous mucormycosis at different forms, and we all might have come across during COVID-19 because there were cases in most of the institutions during that time. And patient come with acute sinusitis, fever, nasal condition, urinary nasal discharge, headache, periorbital or sinus pain, facial swelling, decreased vision and ophthalmoplegia. These are all subtle presentations, but we need to think of these things so that we can have an early attempt to diagnose and treat these patients, because the mortality is very high in mucormycosis as well. The hallmark is black eschar. The fungus is not black, but the eschar is black. That is why the name black fungus. So these are some of the presentation, and this is a typical necrotizing black eschar in these patients, and we have to open the mouth and see whether there is any redness, erythema, all those things, and we need to have an urgent intervention with our ENT colleagues so that we will have an early diagnosis. Diagnosis is from the clinical specimen by identifying the hyphae. CT or MRI will help the extent of the disease, and management, endoscopic evaluation and prompt debridement and antifungal therapy. So debridement, surgical extensive debridement. So we need a very bold surgeon, because it is always, the surgery is also disfiguring. So it is very difficult to make decisions because this is on the face, and we have to have prompt interventions, otherwise patient may die because of the disease, and the disease rapidly progresses and mortality is very high. So these patients require antifungal therapy, regular follow-up, and may require long-term treatment. So this is a 15-year-old boy, male, type 1 diabetes. He went for a tour in a hilly area. When he came, he had fever, ophthalmoplegia, rapidly progressive acute invasive fungal rhinosinusitis with development of palatal necrosis. And on the next day, it proved to be invasive rhinoorbital mucormycosis. In spite of initiating treatment so early, this patient has presented some years back, but we lost the boy because of the progression of the disease was so rapid, and he has actually presented with diabetic ketoacidosis. This lady, 45-year-old female, type 2 diabetes, sudden onset, rapidly progressive proptosis of left eye with the total ophthalmoplegia with cranial nerve palsies. So this culture showed characteristic growth of rhizopus, and that diagnosis has helped us in starting early treatment. But when we present that the patient needs a prompt debridement, most of the time relatives also take some time to make a decision, though we are not able to convince them that this is actually needed for the survival of the patient. This illness, melioidosis, it's caused by Bacteria pseudomallei, gram-negative soil bacterium. It produces many presentations, but most important one we should remember is actually liver abscess, pneumonia and meningoencephalitis. And they mimic tuberculosis because they come with multiple abscesses or consolidation like upper lobe infiltrate. So treatment is early initial therapy followed by eradication phase. This drug is also has to be, if we suspect melioidosis, we need to inform the lab, because the laboratory workers also may have a risk of getting while handling these cases. So this abstract we have presented from cases presented to our institution from 2004 to August 2012, 34 patients with melioidosis, and it has shown that among the 34, 70.6% had diabetes, 24 had diabetes, and the mortality was as high as 29.4% or 30% died. So this is also having a very high mortality. These are the chest X-ray findings: non-homogeneous opacity, multiple abscesses, upper lobe cavity with air fluid level, and it says that fibrosis may not be there as we see in tuberculosis. So I have I think this time is running so fast. Maybe as per this I have only 1.5 minutes, so I'll just keep some of the slides. One thing we have to remember that patients might came with a severe headache, no signs, so it's a clue. Patient may be moving from one physician or one clinician to other with headache, and this case has been moving from because of persistent headache. And ultimately, when she landed up with slurring of speech and her CT and MRI, it was suggestive, and endoscopic sphenoidectomy, debridement, HPR revealed invasive fungal sinusitis, and prompt initiation of treatment has actually saved the patient. So this is one we have presented on the clinical radiological and microbial spectrum of skull base osteomyelitis and its relation to diabetes mellitus, and this presentation also showed that the association between uncontrolled blood glucose and the severity of disease was high in patients with skull base osteomyelitis, and diabetes was the most important risk factor. Periodontitis, we have a very close association with our dental department, periodontal department, and we have done many studies with regard to periodontitis, and it has shown very clearly that there is severity of periodontitis and increased periodontal inflammatory surface area in uncontrolled type 2 diabetes have contributed. This periodontitis has actually contributed to poor glycemic control as well as microvascular complications. And effective periodontal therapy reduce insulin resistance and improve periodontal health as well as insulin sensitivity in patients with type 2 diabetes and chronic periodontitis. And there is a high risk for cardiovascular disease when the patient has got undiagnosed or unrecognized periodontal inflammation. COVID-19 and diabetes I am not going to emphasize. One point I would like to stress, diabetes is associated with about twice the risk of tuberculosis disease and a higher risk of MDR-TB. So if the patient comes with cough, we need to investigate the patient definitely for tuberculosis. How do we prevent? Food care, footwear, moisturizing cream for dry skin, care of bladder, pneumococcal vaccine and influenza vaccine, recognition of warning symptoms and signs. And we need to give patient education. Why they develop infections? They usually say, I don't get infection even with high blood glucose. That is why my blood glucose is normal. That is their interpretation. If there is no infection, that is their normal blood glucose. But we need to tell them that there is higher risk of infection because high glucose, neuropathy, ischemia, examine the feet, and they always have to know that there is a high risk of skin infection, vaginal yeast and UTI, as well as the red flags. And we have to educate with regard to conclude, we have atypical presentations, uncommon infections are there, rapid deterioration, early diagnosis, prompt evaluation and management is the key, and we need to use surgical, radiological interventions, and we have to work as a team. So I acknowledge for some of the slides from Dr. Suma and Dr. C.J. Service, now the HOD of surgery. So thank you for the kind attention. So it's a very huge topic.